For the last talk of this session, I'd like to welcome Laura Collins, who's another one of our esteemed and valued and most collegial, non-invasive member. And she will speak on Women in Cardiology, Powerful Force. Laura?
Good afternoon. Well, thank you, Manos and Subhash, for asking me to speak. And I have a little funny story that starts with email. And several months ago, Manos sent me an email. And, you know, I usually scan my email real quickly in the morning, don't read them real carefully. But if they're from one of my colleagues, I know it's important. So I read the email quickly, and he said quickly, can you do a talk at the cardiovascular, the Dallas, I can't remember the name of it now, but and he put this title, he put this title out, and except he had a question mark after this. And I said, how dare he? So I quickly put back an email and I said, I'll do the talk, but I'm taking off the question mark. And then he shot back an email, he goes, that was the question of whether you could do the talk, not the title of the talk. So with that, I said, well, of course I'll do the talk. Okay. So what I've been asked to address today is sort of the lack of women or the lack of increase in women in cardiology in general. And this is current data showing women in different stages of their training. And as you can see, in medical school graduates and internal medicine resident graduates, women comprise about 50% of the graduating class. However, general practicing cardiologist, 12%, and interventional and EP, about 10%. We have a glimmer of hope because our fellows in training now are up to 22%. Contrast that with our pediatric colleagues, and 41% of our fellows in training there are women. So very, very curious, and the question is why this is and how we can help change this. So the goals, I'm going to present a case presentation, go over the demographics a little bit more, and then hopefully outline the barriers to training and practice and possible solutions. So we begin with a case presentation. This is circa 1990. Okay, so there's a female internal medicine resident who applies to cardiology fellowships. Despite the discouragement of the mentor she had in medical school who said that was too technical of a field. And despite the fact that she had never met a woman cardiologist. So she applies and interviews at 6 programs. Only ranks 2 because at the first program, interviewing with the chief of cardiology, he said, oh, that's irrelevant. Next interview went on, and walked in, and the chief of cardiology said, what are you doing here? Are you slumming? Very odd. Third interview, walked in, again, the chief of cardiology didn't ask any questions about why cardiology, but asked a question relevant to previous programs she had been at, contrast the medical school education, and then said, oh, that's hogwash. Fourth interview, she was the only resident that was interviewing that was given a stethoscope, again by the chair of cardiology, and asked to go on CCU rounds and auscultate every patient. So, 1991, fellowship begins. Okay, July 1st. July 3rd, first child is born. Now, when we walked in to cardiology fellowship July 1st, the response from the chair of cardiology was, when are we going to be a full-time member of the fellowship? And of course, research had already been arranged to be done up front, and so that was explained. So during the period of time, through these 4 years of fellowship, there came some thought whether fellowship should continue because we could call it the co-fellow humor. Many times fellows were changing in the cardiology workroom. And they weren't female fellows, these were the male fellows. And the female faculty members were also, at that time, treated very poorly by the male colleagues as well. So she went to shadow a hematologist, oncologist, to see perhaps that was a kinder field, but was pulled back to cardiology fellowship. And that was completed, and by the time of completion, baby number 2 was on the way. And definitely at that point, it was time to move on. Graduation happened, second child was born, and then job 1 begins at a faculty at a medical school. At that time, research projects were started. Research projects were blocked by lack of equipment or people not sharing equipment, but persevered on. Came time for second job interviews, and at that time, this was about, say, 2003, interestingly, one group asked that her husband, who's not even in medicine or cardiology, come on the interview trail to interview as well. So we had hoped by now that things had changed. So as I was preparing for the talk, I said, maybe I'll do a quick lit search and I'm going to find that things are just dramatically better. So I came across this. It was an article by one of the universities, and the name of the title was Faculty Describe Mood of Fear in the Cardiology Department. And you can all read this just as well, but essentially hostile work environment, allegations of sexual harassment, and this was by the chief of cardiology. The chief was asked to go on an 18-month sabbatical, which the rest of the faculty did not think was appropriate. And finally, the president of the university asked for a task force for gender equity to look at appropriate promotion, salary, etc. In this case, it's still ongoing. So if we look at the number of women fellows in training from the early 90s until now, we can see that although there's been a modest increase, it's not flat. There's been 70% increase actually over these past 2 decades. And if we compare that to women in surgical residency, there's been about a 90% increase over the past 3 decades. As I was preparing for the talk, one of our female fellows was looking over my shoulders, and she looked at this graph and she goes, "That's really a sad slide." And as you can see, this is from AAMC data, and this was in 2008, looking at general cardiologists by age and sex. The purple line is women, and age is on the x-axis here, okay? So you can see that relatively this curve is flat. This does not include fellows in training, but relatively flat. And I think as we go on and we see the baby boomers retiring, and we only have that 20% or so of fellows in training coming on, it's going to take more than 20% fellows in training to sort of increase this number and make the curves come together. So where are the women in cardiology? I mean, in medicine, in general. This is a very busy slide. If they're not in cardiology, and they're not really in general surgery or GI, you can see the majority of women are still in very traditional medical school or medicine subspecialties. OB-GYN, peds actually comprise the majority of practicing physicians are women in those specialties. And it's kind of sad because cardiovascular disease, of course, still remains the #1 killer in women, and yet we have a lack of women in cardiology. So this is a survey. Every 10 years, the ACC puts out a professional life survey to see how the cardiologists are doing in their life. And you can see from this survey that there are more women than men, actually, that practice in the academic setting, and more men than women are in the private practice setting. And what was remarkable from the previous survey in 1998 compared to now is that there had been very little change. You can see that the majority of male cardiologists are married, and women too, but less women. The less women than men have children, and 69% of women at some point in their career had stated they had suffered from discrimination versus 22% of men. Compared, and that was either sexual discrimination or parenting discrimination due to parenting responsibilities. Interestingly, when they were asked about satisfaction in their career, 90% of women and 92% of men said that they were satisfied, and that was an improvement from 10 years ago. So despite all these roadblocks, women seem to be satisfied with their job. One point was that salary satisfaction remained lower for women compared to men. So if we look at the history of women in cardiology, we see that even in antiquity, we had reports of women, perhaps, who were already practicing cardiology. And this person was a mystic or a saint in some religions, and basically used to treat ailments of the heart, including the aching heart, edema, valvular problems, by a concoction of herbs and wine and onion, and to cure her patients. One point to remember is that it's only been 165 years since the first woman graduated from a U.S. medical school. And then in the 1920s, 1940s, the AHA, ACC were formed, okay? And then we started to have the influx. We started seeing a few women come into and train in cardiology fellowships, and not even established fellowships, right? Do you ever wonder why the famous shunt to treat blue babies was called the Blalock-Taussig shunt? And it was really developed by Dr. Taussig and one of the technicians in the lab. We then saw Bernadine Healy come in on scene in the 1970s, and it wasn't until 1987 that the first woman cardiologist was on staff at the Mayo Clinic. Finally, in the 1990s, both the AHA and ACC recognized it was probably time to pay some attention to the lack of women going into cardiology, and special sections were formed in both of these organizations to address that question. So some of you may be out there thinking, why do we need women cardiologists? Why not just have all men? But I think it doesn't take, if you go back that other slide, we want to attract the best and brightest candidates to come into cardiology and to think about problems and to develop new technologies. And we're losing a great number of women, I think, to other subspecialties. Female physicians, no matter which way you cut it, I think communicate differently with their patients. Some of my male colleagues may argue against this, some may agree, but I think that's a real finding, and patient preference often comes in. They prefer to see a woman. And we have real life experiences that men really haven't gone through. So I think there are several reasons why we need women in cardiology. So I like to think of the barriers to training as coronary disease, okay? I think it's sort of has multiple etiologies. It's not going to be the same risk factors for every person that's thinking about a career in cardiology. So I've separated it out into sort of personal factors, work-related factors, and those factors that I think overlap personal and work-related. Now, the American College of Gynecology defines advanced maternal age as more than 35 years. Okay, so that means our fellows who are in training, their clocks are ticking, ticking, ticking. And, if they wait till after 35, they may have more difficulty. Say a little bit, we don't have firm figures on this, but I do think it does exist. Perhaps not unfairly all the time if a woman decides to take a lesser role for the sake of perhaps personal and family factors. And then just because of the numbers being so small, women have had lack of female mentors and role models. And then the overlap, radiation exposure, and I'm going to touch on this a little bit with some recent data, may deter women or have a change in career choice because they don't want to be in the cath lab or EP lab. The duration of and the rigor of the training, I think there's overlap here in both. And then just the work pattern or the call in practice. And then yet something else I learned while preparing is that there's now the Gen X generation are said to be taking the E-road, and I had not ever heard of this before. What is the E-road? So the E-road are the subspecialties which are looked at upon as being kind. emergency medicine, radiology, ophthalmology, anesthesiology, and dermatology. And we know that a lot of those subspecialties are competitive, and it's mostly because of lifestyle. Very busy slide, but this is just to say, what is the deal with radiation? I'll start off by saying the majority of women, both fellows and staff, do not perform fluoroscopy while pregnant, and that's 65%. A good portion, almost 50% of women, will alter their training career to reduce radiation exposure. Now, the mean effective dose for an expert operator is said to be about 4 millisieverts per year. And that recommendation, if you look at the National Council for Radiation Exposure and the International Commission of Radiologic Protection, the recommendations vary a little bit depending on which one of these you're looking at. One of them says you should have less than 1 millisievert for the entire gestation, while one says you can have up to 5, but not more than 0.5 millisieverts per month. The overall recommendation is you probably have to, if you go into cath while you're pregnant, you probably have to decrease your caseload by about half to fall into one of these categories, and of course be smart and wear a monitor under your lead and look at your exposure. Now, the probability in the general population of congenital malformation of childhood cancer is at 0.07%. So you can see if you're under 1 millisievert per year, there's really a very negligible increase in the possibility of this versus if you have more than 10 millisieverts per year or 0.16. Airline stewardesses that fly more than 600 hours during their gestation are exposed on average to 2 to 5 millisieverts. So in any case, even if you decide that you're going to cath during this period, clearly there are some practical considerations, not just the radiation exposure in the last trimester, just being able to reach the table, being on your feet that much. And then importantly, which I think sometimes not everybody thinks about, but when our fellows are rotating through the nuclear rotation, which is often felt to be one of the lighter rotations, they should still wear their badge and perhaps not inject while they're pregnant. So just quickly on the salary compensation, why this isn't clear, it's because it's muddied. We don't know when these numbers come out. They're not usually by age. So people more senior, of course, are going to probably be in a higher earning bracket, and it's not by subspecialty. But in most data that I've looked at, there still seems to be somewhat of a differential between men and women's salaries. Academic appointments are a big issue. We see a dropout after the assistant professor level as far as associate professor and full professors in our U.S. medical schools in women. And it's unclear of whether they're staying stuck at the assistant professor level or if they're just going to other job opportunities there. So just in closing, this is the mission statement for the Women in Cardiology section of the ACC. And you can see that the first one is just to mentor women and the careers of women cardiologists with people who are already in a position on staff in training. And then women residents are next. But they go all the way down to say this should be a focus at the high school, college level, and medical school to get women interested in a career in cardiology. The good news for fellows, this is free. Otherwise, it's $35 per year to join. There are workshops at various times at the scientific meetings and also other times. There's also a virtual mentoring program. So if there's a fellow out there or a medical student out there that doesn't know a female cardiologist, they can sign up and get assigned to someone. There's also a visiting professor program, which you can get a professor to come out and speak at your university. There's recommended books on the website. So I think it's a great resource. And the AHA also has their own cardiology committee. And there's a mentoring award that's given for women in cardiology every year. And also early career cardiologists, 24 are selected every year to participate in a mentoring program at the AHA. So something for our junior faculty to think about. So I'm going to leave you with this. This was a quote by Elizabeth Blackwell, who was the first woman to graduate from a U.S. medical school. Sadly, she was not able to train in the States because she was ostracized for being that first woman and wasn't looked upon very kindly. But I think her foresight was very, very insightful. And she talks about medicine being so broad of a field, and she goes on, blah, blah, blah. And then she says, one of those, medicine is regarded as one of those great departments of work in which the cooperation of men and women is needed to fulfill all its requirements. So I thought that was very insightful for that time. So I'd like to thank Manos and Subhash once again for inviting me to speak, and thank everybody for staying to the bitter end. Thanks.
Who could do a better job than Dr. Collins at 4:45 p.m.? Thank you, Laura. Fantastic. I want to thank all of you, all the attendees, and all the faculty members for this very, very outstanding and splendid day. We have worked hard to put together this program. I hope you understand that, that we have tried our best to fit in all aspects of cardiology the way we see it best. We look forward to your suggestions and incorporate them next year. I just want to say that CME information is available in your handouts. Please log into the website and you can get your CMEs. The Dallas, www.dallascvi.com is the website. We plan to hold the meeting in 2016 and at the same Martin Luther King weekend in Dallas. And I look forward to seeing you all again next year. Manas?
Thank you again. Last but not least, again, thank you. The Dallas Medical Center, obviously, the cath lab personnel being here, the surgery, anesthesia, our research teams. Everyone has been superb. Thanks for coming. Thanks for helping with the organizing. Also, thank Dallas Research Corporation, UT Southwestern, all the sponsors of the event, as well as Gaffney Events for organizing this. So thank you again. Have a nice weekend and see you next year.